Dr. Sadia Sultana is Clinical Fellow of Cardiovascular Imaging at Mass General Hospital, Harvard Medical School. We don't need to talk about the institution where she's at, so that's why we're so excited to have her. And we think in the future, it will be extremely good, resourceful addition to our faculty. She's also former consultant radiologist at Royal Papworth Hospital at Cambridge, UK. The chairperson of the session today, there's two co-chairpersons, Professor Shaheen Islam. We're also extremely proud of Professor Shaheen Islam. He's Chief Division of Pulmonary Critical Care and Sleep Medicine at the Medical College of Georgia. Shaheen has been extremely diligently active with PHA and with several platforms in Bangladesh. And so wonderful to have you as a chairperson. Professor Ali Hossain is with us. Everybody knows Professor Ali Hossain. He's a renowned president of Bangladesh Lung Foundation. He's also professor of respiratory medicine, ex-director NIDCH. জ্ঞানের ভান্ডার যদি বলতে চাই আজকে হয়তো 1 ঘন্টা শেষ হয়ে যাবে. We are very excited to have you as our chairperson, Professor Ali Hossain. As panelists, we have amazing faculty, Dr. Asif Mujtaba Mahmood. Yesterday we had a session এবং আমাদের বারে বারে কথাগুলো টিবির দিকে চলে যাচ্ছিল. And I was thinking, I wish Dr. Asif Mujtaba Mahmood was there. He is a great chest disease and TB expert in Bangladesh. He's senior consultant respiratory medicine at Asghar Ali Hospital, and he's also the esteemed Secretary General of Bangladesh Lung Foundation. Now, the most exciting person with us is, as a panelist, is Professor Rumi Ahmed Khan. Exciting bolbo because Rumi just got promoted as a professor. Rumi amader onek junior. Sejono I'm so proud of your achievements. He is professor Division of Pulmonary and Critical Care, Dell Medical School, University of Texas, Austin. Thank you, Rumi, for joining. We will be extremely excited to hear your comments. Professor Abdul Hanif Tablu, we know him as Tablu. He's professor and vice principal of Dhaka Medical College. He's professor of neonatal and pediatric surgery. He will be joining us momentarily. Two very amazing panelists from Bangladesh, Dr. Farzana Alam. I'm so proud of you. আমি বারে বারে বলি যে অর্ধেক যদি নর অর্ধেক যদি নারী হয় তাহলে পুরুষরা কেন এত কষ্ট করছে? Thank you so much for joining, Farzana. Assistant Professor, Radiology and Imaging at BSMMU, Dhaka, Bangladesh. We'll be looking forward to hear your comments. Dr. Dini Mujahid Farooq Osmani, he's a cardiologist. Wonderful to have you. We know CT is making amazing strides to diagnostic cardiology and may even take over some of the intervention. He's ex-fellow cardiac MRI, University Hospital, Zurich in Switzerland, and he's a cardiologist at BSMMU. Thank you so much, Dr. Farooq Osmani, for joining. So without much further ado, I'm actually the moderator of the session. I'm Dr. Aisha Sigdar, Professor of Medicine and Pulmonology at University Pike, Kentucky. And I will open the session. আমি সবার কাছে ক্ষমা চেয়ে নিচ্ছি. I have some family commitments. I will turn over to Professor Shaheen Islam to moderate the rest of the session. And I will ask Dr. Sadia Sultana to speak. So she's going to talk about CT of the thorax. কেন আমরা CT thorax নিয়ে এত কাপাকাপি হয় আমাদের চেস্ট ফিজিশিয়ানদের বিশেষ করে এবং কেন আমরা এটা এত ইম্পর্টেন্ট মনে করি? আমার মনে হয় if you could dissect the human body without sacrificing a drop of blood, without just without a knife or even a drop of blood. That's what the CT thorax is. ছোটবেলায় মা বলতো না যে তোকে মেরে টুকরো টুকরো করে গাঙে ভাসিয়ে দেব, সত্যিই তাই। sagittal section, coronal section, axial section, তারপরে এতটুকু ছোট ছোট টুকরা করে শরীরটাকে দেখা যায়। That's what Sadia is going to explain. আমি কিন্তু খুব এক্সাইটিং কয়েকজন পার্টিসিপেন্টস দেখছি। ডক্টর লুলু হাবিবুর রহমান আমার খুব কাছের বন্ধু। He's really, Lulu is a scholar in pulmonary medicine in United States. Thanks for joining. আমি আরো দেখছি ডক্টর আদনান চৌধুরী। আমি যদি কাউকে মেনশন না করতে পারি, please speak up at the end of the session. We are very excited. অনেকে জয়েন করেছে। Sadia, it's already 70 participants. So now the boat is yours. Thank you so much, Sadia. And again, I'm so proud of you. Thank you, everyone, for joining. Assalamu alaikum.
Assalamu alaikum, everyone. Thank you so much, Apa, for a very kind introduction. I'm really humbled. আমি বাংলাতে বলি যে আমি এই যখন এই অপরচুনিটিটা পেলাম, থ্যাংক ইউ PHA for giving me the opportunity to be part of this platform. তখন আমি চিন্তা করছিলাম যে সিটি থোরাক্স ইটস এ ভাস্ট টপিক, and আমি ক্লিনিশিয়ানদের জন্যই করতে চাই, but there will be some radiology trainee probably through Farzana Alam Apu, maybe some medical students. So what pitch should I go at, and what should I include, and what should I not include? So আমি কোনো physicianer কাছে opinion চেয়েছিলাম, what do they want to know, and some of them said it's all about lungs. That's what they think about CT thorax. So probably from my cardiovascular background, I put some other information as well. Anyway, you will see. So কারো কারো কাছে এটা খুবই ইজি মনে হতে পারে, কারো কারো কাছে মনে হতে পারে okay, something very rare I'm showing. I'm really sorry. I apologize if it is not very interesting to some of you, but I will start from very basic. So I'm going to share my screen first. I'm going to stop my video to save some bandwidth. So I'm sharing my screen. I just have to reload it. I'm really sorry. Let's do something funny. Just give me one moment, sorry. I'm trying to share.
Toma, you're in the background, right?
Yes, ma'am.
Okay, thank you. Tomar কথা একটু বলতে হয় যে amazing সব organize করে এবং ওকে আসলে আমরা এত বিরক্ত করি। Thank you so much, Toma. It's great. The screen is on.
Thank you.
Thank you, ma'am.
Okay. Can you see my screen?
Yes, we see
Yes.
your screen.
And can you hear my voice cut? Okay, right?
Yes.
Okay, thank you. So, as you said, our talk is about CT thorax. It's mainly directed towards clinician, but as I said, there will be some medical students and trainees, and some of them are from radiology. So I'm going to talk about the scanner itself, very basic things, what we look at. Some points to address before you scan a patient. This is particularly for clinicians. Radiation protection, protocol selection. This is predominantly for radiologists, but why it is relevant to the clinician. Image post-processing, some trick of the trade, basically. Common terminology used in radiology and some quiz cases. So I'll have 12 cases as quiz. If you have a pen and paper handy, that would be really great. And some of you I know joined from phone, but if you have any laptop or iPad or something handy, If you join from a little bit bigger screen, I think the projection is going to be slightly better to appreciate the changes I'm going to explain. And then in the end, we'll discuss about the quiz cases. So this is a CT scanner for the medical students and trainees. This is the X-ray tube, and these are the detectors. And it rotates 360 degrees around the patient, and patient stays in the bore of the tube, and that's how images are acquired. So every pixel gets some information. It's all about shades of grays, and then it formulates into an image by different computing mechanism. So very briefly about other CTs you have heard of, that's PET CT and SPECT CT. So we're going to talk about all about CT, just simple CT, computed tomography, from where we get the information about the anatomy and pathology, but we don't know the metabolic activity. So the PET CT is used mainly to see whether an abnormality is metabolically active or not. So radiopharmaceuticals are injected according to what body part we want to image, and according to the activity, it is scanned. So PET uses positron, that says positron emission tomography, and SPECT is single photon emission. Usually it's a gamma camera that detects it. It's more simpler than PET CT. So this is a PET CT image, which is in grayscale I'm showing, but that's how we look at it. But for you, probably you'll get a colored image to see. And this is a SPECT image of a heart, which is using only gamma camera. And for cardiologists, there is an infralateral infarct clearly seen by you probably. So this is a PET CT. That's how probably it comes to you with lots of color coding, and you can see the metabolic activity. So we assess some normal areas, some abnormal area, and we do hybrid imaging. So we do some CT scan with it so that we can co-register and do some attenuation correction when we interpret the scan. This is an MRI scanner. For the trainees who has never seen one, it looks almost exactly the same as a CT scanner. This is a huge magnet, actually. It uses a different property of the tissue. It looks at the hydrogen molecule of the tissue. So this is the scanner, which is basically the magnet is more than 30,000 times stronger than the gravity. So imagine how strong the magnet is. That's why the room looks so empty. We are not going to talk about MRI today. That's another topic for another day, just to show you how the scanner looks like. So what we are going to do today is mainly talking about CT. So what are the indications for CT? Why do we do a CT thorax? So after clinical assessment and some blood results, if you need additional information, then you do CT thorax to see inside. Sometimes it's very useful to clarify a chest X-ray abnormality. Suppose something in the mediastinum you think may be abnormal, but you cannot locate it, or you don't know what kind of abnormality it is. So imaging of tumor, it's very important, maybe benign or malignant. You sometimes do it for acute symptoms or maybe some chronic things. CT thorax is generally done for lung, as most of the clinicians believe, but other parts of cardiac imaging, vascular imaging, lung cancer screening is a big thing in Western world at this moment, and there are a lot of CT thorax done to screen high-risk patients for lung cancer for early detection, and CT-guided interventions are part of CT thorax as well. So this is very important for the clinician. Why I mentioned, because this is, I worked in England and America, and all the clinicians, particularly junior doctors, when they start their rotation, they are always briefed about it in their induction training. So what is the clinical question? It's very important to be very clear about the clinical question. And in your mind, as a clinician, you need to think how this imaging can help answer this question. Is it this specific CT scan we need, or do we need a PET scan or MRI? You need to think about the modality, or it can be done through just simple chest X-ray. Which body part to include? So if you tell me I need a CT thorax, but you are actually looking for a metastatic cancer, then the patient has to come back again for another body part scan. So sometimes think about whether you want to image chest, abdomen, pelvis or not, you put it together. How can you communicate the clinical question with the radiologist? That's a huge thing. We struggle every day, even in America. I struggled in England, we struggle in everywhere, basically, this communication problem. So the clinician would say acute shortness of breath, or say, okay, no coronary artery disease, and request a scan, like as a checkbox. But we have to dig out the history and see what exactly you want from us. So whatever the clinical information you have, we may not have all of it, particularly in Bangladesh, because it's not online system that you look into the notes straight away. You may need to find out from the clinician. Most of the time, what we do as a radiologist, we don't have time. So we just guess, what you want, and then we protocol it. I'm going to come to protocol because that's extremely important to get a good scan, to give you the correct information you want. So I'm going to emphasize again and again and again on this. It's the communication between the clinical team and radiologist is the most important thing in radiology and to manage a patient clinically. Radiation effects you need to think about in specific scenarios, like if a pregnant patient comes with chest pain, whether you want to do CT pulmonary angiogram to rule out pulmonary embolism, or a VQ scan can be done, or any alternative methods are there. Radiation effects are more important for children because they've got longer life expectancy, so cumulative dose of radiation may induce cancer in them in future. For patients over 70, radiation dose is not a big matter anymore because the scanners are so fast. There are the 5th generation scanners are there now. For the new trainees, generation 1, 2, 3, 4, it's mainly depends on how the image is acquired, what are the number of detectors, what's the length of the scan, and also the radiation dose. Image post-processing is a different thing. So just for an example, the radiation dose is really low now in a way that if it is clinically indicated, we often scan pregnant patients, and children are scanned using dose modulation method. So there are particular parameters we change in the scanner to make the dose as low as possible. Just to mention, we can scan a beating heart in 50 milliseconds. So 1000 millisecond equal to 1 second. So imagine what is the time span of a scan is 50 milliseconds. So the other consideration you have to have is renal impairment and contrast allergy. So we use iodinated contrast for CT scan, and some patients can be allergic to it. And some patients may know that they're allergic to it. So you need to clinically assess what is the level of allergy and what medication you can give. So maybe 1 or 2 scans a week I do. Patients are on pre-medication, some steroid and some antihistamine to get the scan done. So it's still safe, but you just need to be extra cautious with patients with contrast allergy. Renal impairment is a big thing everywhere. But actually, all the recent papers, meta-analysis, are showing that there is nothing called contrast-induced nephropathy. So you may relax, basically, about it. So contrast doesn't cause renal impairment. It's basically the other comorbidities patients have already renal impairment, or septic patients. They may have higher chance of having some renal deterioration after contrast. So we use eGFR here, but you can use creatinine if your institute doesn't give eGFR. But usually eGFR is calculated from serum creatinine levels. So it's quite easy to get. You can call the lab and say that what's the eGFR. So we use the number 30. So if it is less than 30, we inform the clinician that you need to pre-hydrate. It's not a contraindication as such. You may need to pre-hydrate or post-hydrate, maybe with oral or IV fluid, depending on what. And patients, particularly on dialysis, when you scan, it's very important to coordinate the timing of the scan with dialysis time. So immediately after, or not immediately, on the same day of scan, if the patient had dialysis after the scan, then contrast will go out of the system. So these are the special things a clinician need to think about before doing a scan for a patient. So the protocol I was talking about. So for us, radiologists, we protocol the scan according to your question. So it can be non-contrast. So suppose you want to see interstitial lung disease or TB or something, then we can do without a contrast, very quick scan. But if you have question about any of the blood vessels, I'll show you the scans. it's impossible to comment on the blood vessels if I don't give contrast. So don't request any scan. You want angiogram off without contrast, okay? So if you think there's something wrong with the aorta or coronaries or pulmonary artery or pulmonary vein, we can do all together. So if your question is, I don't know, just tell me whether there's anything wrong with the aorta, whether this patient has got pulmonary embolism, or there isn't anything wrong with the pulmonary veins or left atrial appendage, or there's a clot in the heart. We can protocol it. We can do one scan because we can administer contrast, timing, and everything. We can titrate it. So we can answer your question if you're in doubt. But it's better to have one question, of course. For cancer staging, we need contrast for sure, because lymph nodes will be better appreciated. I will show you. Pleural pathology, if you say just simple pleural effusion, that's fine. If you ask for empyema, we need to give contrast because we need to tell you maybe infected or not. But anyway, it is clinical diagnosis as well. ECG gated and non-gated, I will come about it. So basically, how we acquire the scan for the gene. Sorry.
Sorry to interrupt. You're in the presenter mode? Is it any way possible to go to full screen mode so they can see the pictures bigger?
I'm in the presenter mode.
Yeah, because I can see your next slide.
Can you see my next slide?
No, because it's showing up as a smaller window on the right side, the next slide. So if you go to your slideshow.
Okay.
I think she needs to go to slideshow. Yeah, slideshow.
If you go to your slideshow and then pick.
I think what's happening there when she's sharing the screen, I think the wrong screen is being shared. She's in
okay, that's right. Okay, I'll stop sharing. Then I will go to screen share again.
Yeah,
just if you
the right window.
Give me 2 seconds.
Sure.
So it did it once.
Unless you have two, do you have two screens?
I've
on your
got two
computer?
screens.
Yeah.
Okay, so that's why it's doing it. So you have to pick the window that you want to share.
Yeah. She has to
Or go into the mirror mode.
Okay. I don't know what it is, why it is doing that. Okay, it is sharing. Okay, anyway, I can go to, okay, it's giving me the other screen. That's the problem. It was doing, okay. Stop share. If I take the other screen out, probably it will be better. Give me 1 second. Okay.
Sorry about the interruption.
No, sorry. I didn't know that it's happening. Thank you so much for telling me. I don't want to show you my notes, my secrets. So
if you just do mirrors.
No, I can share. I can share the bigger screen now. I just disconnected the other screen. So share screen. Okay. There we go.
You got a slide.
Is it better now?
Yeah,
Much
now
better. Yes, thank you.
Sorry about that. Okay, anyway. So sorry, I went to, okay. So how we acquire the image, we take a scanogram or topogram for juniors. So basically for the radiology juniors particularly, always look at the scanogram because this is wider than what you do at the CT scan because this is a collimated one. So we don't want to radiate the abdomen. So when we first position the patient in the scanner, we do the scanogram or topogram, and then you get we cut it down up to there. So if patient comes with chest pain, you don't find, I had a case only 2 weeks ago who came for coronary CT angiogram, didn't have anything in the lungs or heart, had a big gallstone, which of course was not visualized from the CT thorax. So always look at the scanogram. That's how we scan anyway. And contrast enhanced or not enhanced. So for junior trainees, what we do, according to your question, again, the clinician asks about, okay, show me pulmonary arteries, show me pulmonary embolism, we select that. So the way we do it, we ask the machine to trigger when, if we want to see aorta, this is for aorta, so we put the ROI there. If we want to see pulmonary artery, we want to say put ROI there. Sometimes it is done in a different method that's called test bolus. So the technologies determine the time according to cardiac activity, basically cardiac function. But most of the scans are done, which is set up by bolus tracking. So the machine decides when to start scanning. So the technician doesn't have to show it. So the phases of contrast, I'm probably reiterating the thing again and again. That's what is the timing of contrast? Depending on that, I can give you answer. So it's different phases. This is, you can see both aorta and pulmonary artery. This is aorta and pulmonary artery is not opacified. So if the Hansfield unit of pulmonary artery is less than 250, I'm not going to be very specific about whether there's a small P in lobar or segmental pulmonary arteries. But if it is properly opacified, it's very sensitive and specific, picking up small abnormalities. Sorry. So ECG gating, I was talking about. This is a patient from last week, basically. The reason I wanted to show to the cardiologist, the clinician deal with acute illness, like in ED situation or intensive care. You need to know, and a lot of clinicians, even in Western country, don't know this ECG gating. I work in a very developed city, I would say, but most of the scanners don't have ECG gating. Scanners have, sorry, but the technologists don't know, the radiographers don't know how to use ECG gating. So patients with acute chest pain, they do aorta imaging without using gating, and we get this image. And I think 2-3 days ago, a cardiac surgeon rang me at 9 o'clock at night. I was on call. Say, okay, can you tell me whether there's acute dissection or not? So this is, so for the junior trainees, this is a line that looks like a flap, and that's how dissection looks like. Aortic dissection is a life-threatening emergency situation. But the difference is, I just told her, this is not gated because there's a lot of motion. Heart is always moving, right? So this is not gated. Just get a gated scan, and then I can tell you, this is the gated scan. Look how clean it is. And there is no flap. So I have seen patients in a tertiary center being operated on this scan, and they opened the chest. They did thoracotomy in a young 37-year-old, looking at this scan, and aorta was absolutely fine. So think about, like, what about me going to hospital having this kind of management? You don't like it. So always, you can never comment on aorta, particularly aortic root or ascending aorta, without doing ECG gating in terms of whether there's acute dissection or not. That's the main thing, or acute aortic syndrome. So ECG gating is used. We put the leads on the chest, and then we ask the machine to trigger at, this is systolic imaging, so 200 to 440 millisecond of cardiac cycle, and it gives us this motion-free image. Not all technologists know it, so not all centers can do it, but if it is available, that's the best thing to do for these type of patients. So concept of Hansfield unit, I'll be using a lot of Hansfield unit in my talk. So it's basically differentiating density. So this is a number, unitless number. This is crucial for determining the density difference in terms of problem solving. So radiology is basically pattern recognition. So you see something normal and you compare with abnormal, and you know this is abnormal. But sometimes density of the tissue may look the same. And what we do, we put our cursor, and it gives us a CT number and express as this. And water is always 0 to may go up to 10, but higher than that, you may think it's blood. I'll show you some cases, then you will know. Bone is quite dense. Contrast depends on the concentration, usually similar to bone, if the contrast opacification is good. Lung is always minus, fat is minus, and air is always minus. So this is how we do the density difference. Suppose this was, I didn't know whether this is a bit of fluid, or is a solid organ, or is a hematoma. Then I would put my ROI. It's available in every PAC system. If you see the images with a DICOM viewer, you can see, I know most of the clinicians in Bangladesh don't get CD images or look at the images on PAC. So for them, I have got other methods. So that's how we do it. This is with contrast, this is without contrast. Without contrast, this is containing blood, that's why it's 50. And with contrast, the mean has changed to it. We look at the mean, we don't look at this. Windowing is another thing. So when I asked one of the clinicians a couple of weeks ago in Bangladesh, what do you look at when you look at a CT thorax? And he just straight away said, I look at the lungs. You can see lungs only. So actually, then initially I thought this presentation is going to be all about lungs, but then I changed my mind. I thought that, okay, people should know a little bit more what we can see in a CT thorax, basically. So window. So what you get is a lung window. You can see lung. If I give you on the film, you're a clinician, I'm a radiologist, lots of films of this image, and you want to interpret lung, that is impossible. This is a soft tissue window or mediastinal window. You can see mediastinal structure, soft tissue on this window, and you need to get lung window to assess lung. Similarly, you cannot assess bones like little fractures or little metastatic lesion you cannot see without windowing. So windowing is to increase contrast in the soft tissues, basically, according to whatever preference you have. Most of the PAC system has got a set window. So you can say, I want lung window, I want to just click on it. But you can change it manually using your cursor mouse as well. So this is bone window. Look how it is set up. This is window width and length. I'm not going to go into the physics of it. So anatomy in different planes. So that is extremely important. You can see sometimes, I will have some examples as well, a mass looking like maybe 2 centimeters. But if you go to coronal plane, it may be a flat atelectatic band. So don't assess the size of it only looking at the axial plane. So images are acquired. So for the junior trainees, we slice the body into millions of pieces. So it is volumetric acquisition. So now the scanner, the smart scanners, most of the scanners from 3rd generation to 2nd generation onwards, they do volumetric image. So there's no gap in data. And you can get any type of reconstruction you want. Doesn't matter what thickness you want, what type you want. I will show you some of those. So you need to look at axial. This is coronal, and this is sagittal. So from side to side, and this is from front to back, and this is axial images. So we are going to talk about anatomy now. So I chose, of course, lung window, because everyone is more interested in lung. But this is a post-contrast image I chose because I want to show you how contrast comes. So I'll go to the beginning again. So from left subclavian, it's a left arm injection. From left subclavian vein, it goes into the, so going down, brachiocephalic vein, SVC, now going down. It's going to the right side of the heart first, and then right ventricle, and then go up. So pulmonary artery has gone already. So when you look at a scan, you think whether you want to go craniocaudally or caudal, so basically top to bottom or bottom to top, according to how it is displayed on the film. Sorry, I don't have film, but for clinician who gets film, you need to look one structure at a time when you go through it. So I tried to make some film. I will show you in a minute. So this is lung window. So you look at this is the right side of the body, by the way. This is left side of the body. Imagine you're looking at a patient from the leg side. So this is the right side of the patient. This is the left side. That's the orientation. So you can see the airway, how it is going in. This is a scrollable image, which is difficult to follow, but I will go to the airway. So if you follow the airway, on the film, you follow the airway only. Don't look at any other structure. You'll get distracted and you'll miss something. So this is the carina going into the right main bronchus, bronchus intermedius, and going into the right middle lobe, right lower lobe. On the left, it is already lingula, and this is left lower lobe, divided by the fissure. I've got other images as well. So I'll go to the next slide. So I tried to give you other planes as well. These are soft tissue window. I'll be talking about the window again and again and again, because the quiz cases I have, it's all about a window, because you need to look at specific structure in specific window. So this is soft tissue window in a sagittal. So it's going left to right. So you can see how things are looking on this plane. Okay, I'm not going to explain. This is coronal. So that's how the So these are all axial images reformatted in these planes. Okay. So looking at the lungs. So I'm talking about the fissure. So everyone knows anatomy, I know, but it's very difficult to see the fissures. So fissures are pleural reflections, basically. So this is the oblique fissure from the top. So it's coming, when you scroll, you can see how nicely it comes like from top to bottom. So I have 3 different images of the fissures. So this is horizontal fissure. So on the right side, upper lobe, middle lobe, lower lobe. So between horizontal and oblique fissure, abutting the mediastinum is the middle lobe. On the left side, usually there are 2 lobes, but some patients with heterotaxy syndrome may have 3 lobes. Sometimes people have azygous lobe, that's an accessory lobe, which is a normal anatomical variant. So on the left side, this is the oblique fissure coming down. So it's imaging is in a different plane. I said it looks a bit different, but this is lower lobe. And this is the fissure on the sagittal plane. So this is the upper lobe and this is the lower lobe. Mediastinal anatomy is very important to understand because different pathologies happen in different compartment. So this is anterior mediastinum, this is middle mediastinum, this is posterior mediastinum. But International Thymic Malignancy Group now decided to change it. Now means 2017, because there's a big discrepancy between how we radiologists talk about mediastinum and cardiac surgeons talk about mediastinum. So they put it as this is not anterior, this is prevascular mediastinum, and middle mediastinum is now visceral mediastinum because all of the viscera lie there, and posterior mediastinum is now paravertebral mediastinum. So if you come across those terminology from radiologists or cardiac surgeons, that has come from the ITMIG group from 2017. So a little bit about the aorta. This is volume rendered image. So for the trainees, the bulbous portion is the aortic root, and then ascending aorta, arch starts there where the brachiocephalic artery is. Sorry, this is, I will, if I put it this way, it will be easier to understand. Okay, so this is the brachiocephalic, left common carotid and left subclavian. Arch is down there, then descending aorta. So I tried to make some films for the clinician, but I failed really badly because I didn't know how it is displayed. I have never worked with CT films before. So here, you need to look at left and right side separately, unfortunately. So this on the left side, you go clockwise, and the right side, you go clockwise. So on the top, I just put some slices. Otherwise, the talk is going to be lengthy. This is non-contrast images. So you can see the 3 vessels, the arch branches, then the arch coming down, sorry, there, ascending and descending aorta, aortic root, and then coming down, heart starts, coming down, then you can see part of the upper abdomen as well, because always pleural recesses go down to the abdomen. So this is the lung window, similar things I wanted to show. So upper lobe, and then going down, you can see where the trachea bifurcates. So there, this is the right middle lobe bronchus, this is the lower lobe. So this is middle lobe, lower lobe, and then now it's going, going down. This is further down, lower lobe, middle lobe, and this is lingula. This is post-contrast images, similar. I just wanted to show how you want to go down, but the display is not optimal. So as I said, contrast looks a bit different. So what we do is, as a radiologist, this is the trick of the trade. Basically, we put the images in multiple planes, so axial, sagittal, and coronal, to appreciate any abnormality. Usually, axial is enough to diagnose a problem, but for problem solving, you sometimes need other planes. And if you want to let clinician know what you're talking about, sometimes it's very good to give other planes and save it on PACS or on the film. We do oblique reformatting as well. Card planar reformat we do to straighten a vessel. So that's mainly for vessel. And thickness we changed. Intensity projection images for radiology trainees. We use maximum, minimum, average intensity projection. But the main thing is maximum intensity projection for lung nodule detection. I will show you why. And we do volume rendered images, the one I showed on aorta. Because If you, some of you remember this famous picture of Prince William, Prince of England. When he had a baby, he showed this. So some photographers took it very offensively, and then basically he was showing three. So if you see one object from one plane, it may look, or interpretation may be very different. So you need multiplanar images. So that's the multiplanar images. So that's MIP. MIP is basically that accentuates areas of high densities. So if the nodule is not seen on the normal lung window, a radiologist, or if you use PACS, you can use MIP to get a little lung nodule. So this is carved planary format to see the vessels. And these are volume rendered images, pretty pictures we can make as well. We never diagnose any disease from these as a radiologist, but it's always good to give to the clinician, particularly surgical planning making. So special terminologies we use: speculated. So those are the spicules. That is very sinister. We try to communicate with you. I don't like it. Stranding. This is clear fat. This is dirty fat. Stranding, we say sometimes there's stranding around, and that means either it's inflamed or invaded or something wrong going on with it. High fluid, high attenuation, low attenuation, we use for high density and low density structure, kind of synonymous. We use indeterminate a lot because we want to say, I don't know. Invade and abut. So this is abutting nodule, and the other one is invading. So invading means it's not good. Sometimes we say likely, means I think 90% I'm sure, but radiology is never sure. So likely means it is. Convincing, consistent, you know that we are very sure, and suspicious is suspicious. You investigate more. That's the communication from our side. So very quickly, 12 questions in 6 minutes, a very rushed quiz, but if you have a pen and paper, it's for self-assessment, nothing for me. If I was present in front of the audience physically, then I would be able to ask questions probably. So I will start now. The first case is 44-year-old male with shortness of breath. So for the trainees, some cases are very easy, some cases are not, what you can see. So when I put, first housekeeping thing is, when I put soft tissue window, that means I want to want you to think about the soft tissues, okay? So anything abnormal in the soft tissues, don't look at the lungs. Next case is a 64-year-old man who presented with shortness of breath after a long haul flight. I think he flew from Sydney to America. And he was tachycardic, and his blood pressure was low. His saturation was 88% on 5 liters of oxygen. So I want to, this is a post-contrast image, so you need to look at the vessels, whether you can see anything abnormal or not. 58-year-old female with progressive shortness of breath. This is lung window, so you need to look at the lungs. This is axial and this is coronal. So same patient in 2011, this is the CT, and this is in 2022. This is a 58-year-old smoker, had a lung cancer screening CT. So you just look at the lung window because they put on a lung window. I'm going very fast because we need to discuss these cases. So I have got a zoomed in view of the lung as well for you to appreciate the problem. This is a 48-year-old female with chronic cough. This is a 70-year-old gentleman who was biking and he fell and came with chest pain. So first look at the chest X-ray, whether you can see any abnormality, and then look at the CT and lung window. A 37-year-old male with non-specific chest symptoms. So I put two chest X-rays 3 years apart. This is 3 years ago, and this is I think 1 year ago, but the interval between the two chest X-rays, so 3 years. One is normal. This is normal. This is abnormal. So think what is abnormal very quickly. Then I will show his CT as well. This is the CT. So this is axial and this is coronal. I want you to look at the soft tissues in the blood vessels, not the lung. And he had a PET CT as well. So this patient had a motor vehicle accident. It will go very quickly. So look at the lung window. I don't think you can look at everything on this one, but I will play twice. So if you have finished following lung, you can now follow the tube probably. It's very fast, I know. 57-year-old female had a chest CT. Sorry, it says chest twice. For an acute reason, had an incidental findings. So incidental findings is this small nodule. I tried to zoom in, but the resolution is not as good. 2 years later, she presented with this. This is the PET CT. This is the lung window. Next is 67-year-old. This is my patient from last week, came in with shortness of breath. So this is post-contrast images in soft tissue window. So you know what to look at, sorry. And this is a 39-year-old with known connective tissue disorder. If you think anything is abnormal, you can write it down for yourself. I'll concentrate on the mediastinum. And it was, if you think it wasn't picked up, then 2 years later, this patient came in with this. The same patient. This is an image of different patient, but this happens to similar patient. That's why I put it there. So this is axial, this is sagittal image. If you can see the abnormality. This is a case from last week as well. For I don't know, fortunately or unfortunately, all of the cases are within the last week or so. So this patient had a bioprosthetic heart valve. You can see this metal density there. Presented with fever after some dental work. Is there anything abnormal you can see there? This is very important for the radiology trainee, if there is any. Extremely important to identify this. I've got the last case, which is 46-year-old only, has got some atypical chest pain, has been investigated previously in the USA with 3 nuclear perfusion studies, which were negative. And now primary care physician just got fed up with him and then sent for a CT coronary angiogram. So this is not coronary angiogram. This is a non-contrast images of the chest, you can say. So if you can see anything abnormal, there's no contrast here. Okay, so we're going to answer and discussion. I cannot say or see how you did, but it's for your self-assessment to spot the diagnosis. So we'll go to the first case. So this is very simple. This is a pleural effusion I was going to show you. So pleural effusion, small pleural effusion. So this is the pleural space for the trainees. On the right, there is none. On the left, there is some basal atelectasis as well. If I put it in the lung window, you'll be able to see the basal atelectasis. So this is pleural effusion. So if you ask me as a radiologist, tell me whether it's blood or is it simple fluid. From the look of it, I can say that it is most likely, probably 70% likely it is fluid, simple fluid, but it may be blood. I don't know. So what I do, I put my cursor to do the ROI and I get Hounsfield unit of 12. So I'm 100% sure it's a plain fluid. It is not blood. That's how we are so sure about hemothorax or hemopericardia, because we know what will be the Hounsfield unit. So next patient, probably most of you could identify something is wrong with the pulmonary artery. What is wrong is all this low attenuation area, so lots of thrombus in the blood vessel. So had a PE after the long haul flight. So it's a big volume pulmonary embolism basically. So I have got scrollable image. It's displaying a bit flat, but you can see what is the volume of thrombus, and right heart is slightly bigger than the left heart with the septal flattening. So when we do pulmonary emboli imaging, we sometimes try to, as a radiologist, try to give the indication how, although clinically you know, the clinician, how bad the volume of thrombus is. This MPA, this main pulmonary artery is bigger than the aorta. That means there is a large volume thrombus causing pulmonary pressure to go up, and that is causing back pressure to the right heart. So right heart is enlarged as well. With the interventricular septum is flat. Sorry, the projection is not perfect. So this patient also had pulmonary infarct and some hemorrhage as well. Sorry.
Sadia, could you go back to that one and just show them that how a saddle embolus would look like, the CTP,
Okay.
yeah.
Sure. Yeah.
And then the right and left pulmonary artery. So I think that it'll be very helpful for the participants to know.
I'm rushing a bit because of the time.
Don't worry about the time. I think it was a very
Is it
good
okay
lecture.
to go a little slowly? Okay.
Yeah, probably.
I
I
didn't
think.
want to rush. So this is saddle embolus. Okay, so it is straddling over the bifurcation. It is going both into the right side and left side. So the mechanism of it for the clinician, you all know, it's usually after long haul flight is DVT. So if you Doppler the lower limb, you will be able to find filling defect in one of the veins of deep veins of the lower limbs, and that travels through the IVC, come to the right heart, and then it goes into the pulmonary artery. And that is a life-threatening condition. This much volume of clot can kill a patient very shortly. You have seen he's a young man, but his saturation is only 88% on 5 liters of oxygen. So he is compromising. The other thing is the assessment for the radiologist, assessment of the right ventricular compromise in terms of right heart pressure increase or PA enlargement is important because some patients are candidates for thrombolysis. So I don't know whether it is done in Bangladesh or not. That's why I didn't go there. But these patients are very good candidate for thrombolysis, sometimes thrombectomy. They do mechanical thrombectomy of the pulmonary artery as well here. So it's very important to say, and they come to us. They come to us and say, "Can you tell me, is there any right heart strain or not?" And this image is not that great, unfortunately, but basically the right heart chamber will dilate and the interventricular septum will be flat with pressure. And there will be some regurgitation in the IVC. Contrast comes, I showed you, from top of the body. So from brachiocephalic to SVC, it shouldn't go into the IVC, particularly hepatic IVC. You will see lots of that's sign of tricuspid regurgitation, basically. Those are all combined sign of right heart strain. And these patients are candidates for thrombolysis. This is a small filling defect. So that's how small PE looks like. And this is acute PE. If it's chronic for radiology training and for a pulmonologist, it layers around the artery rather than being in the center. This is like what it is called Polomid sign for acute thrombus. So this patient also had on lung window, if you go, there is pulmonary hemorrhage and infarct. So that is the consequence of the pulmonary embolism. Our third case was this case with progressive shortness of breath. As I showed you the image in 2011 and 2022. So I don't know whether some of you appreciated this abnormality. So if I say this is normal lung, this is abnormal lung. I'm sure most of you identified. But some of you probably thought this is emphysema, because I used to think as a clinician when I used to see that it may be emphysema. But if you see this has got a wall, I will show you the cases of emphysema where there is no wall. I've got, I think next case is that, just to differentiate. There is interstitial thickening, and this is very peripheral and subpleural. If you see the distribution is lower zone predominant. So there is architectural distortion as well. So this is lower zone predominant, subpleural, peripheral reticulation with honeycombing. So these little cysts, which are stacked one after another, are called honeycombing. So these represents pulmonary fibrosis. This is an interstitial process. I'll show you the emphysema case, but this is interstitial process. This is managed completely differently than emphysema or other causes. I'll show you. When you see these cases, you need to think about if the distribution is at the top, the differentials are different. if the distribution of the fibrosis is predominantly at the bottom or mid to lower zone predominant, the differentials are different. So upper zone predominant causes are mainly, you see probably in clinical practice, TB, sarcoid, radiation, but lower zone is predominantly EYP pattern, which is maybe NSAIP or EYP. IPF, when it's idiopathic, there's no cause. Connective tissue disease, asbestosis, or aspiration can cause it as well. Drug-related fibrosis is usually upper zone. So this is the progression of the disease. So if you see preliminarily, it was mainly interstitial thickening. There was not much traction bronchiectasis. Probably there's a little bit of traction bronchiectasis. There's a big difference between traction bronchiectasis and primary bronchiectasis. So this is not primary airway pathology. This is primarily interstitial pathology, which is putting traction of the bronchi and dilating it, basically. So these are all traction bronchiectasis. I will show you the emphysema case. Then no, this is primary parenchymal pathology. I showed you the case 4. So there are holes in the lung, and that doesn't have any wall. So there are big holes in the lung. So these are emphysematous area. So with this one, I gave you some paraseptal emphysema, which is pleural based mainly. You can see it near the fissure or periphery of the lung. So the difference between emphysema and interstitial lung disease is the pathological start of the disease is completely different. This is a patient, I didn't show you on the quiz, but additional case. If I had audience, I could ask, what do you think about these holes? So all holes, right? So these are not emphysema. These are lung cysts. These are air cysts, because if I differentiate this, there is no wall to it. It's just like a permanent destruction of the lung parenchyma. But there, these have got little walls. So this is completely different pathology. This patient has got lymphangiomyomatosis, so LAM. LCH can cause it as well. So differentials are completely different when you see cyst with wall. If there's one or two, that may be previous infection or some trauma, something causes little nematocells. But there is numerous of varying sizes. You need to think about the other pathologies, other underlying condition. So these are not emphysema or interstitial process. So I had a close shot of that to show you the wall. So just to differentiate, this is emphysema and this is interstitial lung disease. So there are holes without any wall. These are very irregular. It may be very mild like this or moderate like this, or the severe one I have shown you. And this is interstitial lung disease. And bronchiectasis is primary bronchial pathology. So look at the bronchi. The lung parenchyma is okay. It's mainly centrally distributed. And the case I showed, those are all peripherally distributed. So the pathological process, if I start talking about it, it needs a different lecture, the interstitial lung disease part, to be honest, which I plan to do in future. But for this patient, this is a cystic fibrosis patient, actually, who the junior doctors who know this, the CFTR gene mutation that causes thick secretion. I'm not going into the pathophysiology. And they eventually get bronchiectasis. So see how the airways are dilated and there's thickening of the airway and some mucus plaquing as well. So this is upper zone predominant and this is cystic fibrosis patient. Post-infectious bronchiectasis you see for COPD patients, usually lower lobe predominant, sometimes only middle lobe and lingula, but for cystic fibrosis, usually upper lobe predominant. And this patient also didn't have something, that is the pancreas. So there's a lot of fat there. So this is normal pancreas looks like, and this the patient had vanished pancreas. So they get the cystic fibrosis patient get atrophy of the pancreas and looks like there's nothing there, but actually the pancreas is replaced by fatty tissue. The pancreas is absent. This is a normal patient. And this is a very simple case. Everyone got it, I guess. So from chest X-ray, you can see there's a pneumothorax. So if you can see, I don't know what you're using, but probably the projection may not be optimal, but you can see the lucency with the lung marking. It's difficult to appreciate in the upper zone, but in the lower zone, you can clearly see there's no lung marking passing through. So for the junior doctors, how we differentiate anything from pneumothorax is you have to see a lung margin. and there's no interstitial marking going through that clear space. So if I ask you to compare the right side to the left side, you see the lung markings coming through, there's no pneumothorax, and there is basal pneumothorax. On CT of the same patient, you can see the apical and basal pneumothorax. So this patient had pneumothorax, and this is the post-chest drain. This is the pleural drain placed in, and this compressed lung, collapsed lung became inflated again. Most of the cases, you don't need a CT for pneumothorax though. So this is a very interesting case. He's 37 and this is normal. And he came in with non-specific chest symptoms. So whether you can appreciate there's a bit of fullness there, right? So that's a mediastinal mass or some kind of mass overlying the hilum, right? You can see the hilum. So he had a CT and I showed, so that mass is looking like, so this is, if you correlate with the chest X-ray, probably you can see this mass is causing the fullness and the silhouette is lost there. This is the axial image. There is a large mediastinal mass with a small pleural effusion. So this mass was active peripherally. This is, as I said, PET CT is to see metabolic activity. So on CT, I can tell you there's a mass, but I don't know what kind of activity it has. Is it completely cold or is it hot on PET or what it is doing? So we give radiopharmaceuticals and there is some activity there. So the PET staging was done for this patient. The only active part was the thymic mass. So he was operated on. So he was cured from his problem. So the debulking was done. They said all margins are clear, but unfortunately he presented a year later with this. So this is a pleural invasion from drop metastasis from the thymic malignancy. So as you can see, there are metastases in the pleura. So if you see right side of the pleura is clear, on the left side, there are dense structures. So this is again, soft tissue window. This is not lung window. So you can see the fat plane is lost. So invading in the pleura. There are some lung nodules as well. So he had a radical pneumonectomy on the left side and still on chemoradiotherapy as of Friday. I checked his notes. So I didn't have many differentials in terms of pictures to put. So I took these pictures from radiographics article. So anterior mediastinal masses can look like that. If you could scroll, you could see it's coming from thyroid. It looks very sinistery, but it is not. You can see teratoma, which is a big fat-containing mass in the anterior mediastinum. The way you can see fat visually from the subcutaneous tissue and the fat inside the mass is the same density. And you can put your ROI to see what it will be minus for sure. There's another one, this is a thymic cyst. So if you put ROI, it's going to be either 1 to 10. There's a posterior mediastinal mass. This is a neural tumor coming from the neural foramina. This is a very, very regular outline, a bit heterogeneous. This is a patient with myelofibrosis who has got these lumpy, bumpy masses. These are all extramedullary hematopoiesis. So that's how it looks like on the coronal plane. Is paravertebral masses going into the, so it's paravertebral mediastinum rather than posterior mediastinum now, according to the new nomenclature. So this was our trauma case. So almost 100% of motor vehicle accident or road traffic accident comes to ED. They all get CT of the whole body usually, including head. So this patient, what you can see first, this is lung window. So in lung window, you can see air very well. So for all the trainees, I would recommend to use lung window to exclude pneumothorax, to exclude pneumoperitoneum, anything pneumo you want to exclude, it has to be on lung window. You cannot exclude it in soft tissue window. That's impossible because it all looks the same. So what this patient had, so this is a tertiary care center where I work, and they saw the big pneumothorax. I think the paramedics put this chest drain in. And unfortunately, this is in the lung parenchyma. If you put it in other plane, you can see sometimes the chest tube can follow the fissure, and that's still the pleural space, but this was definitely in the lung parenchyma, and you can see the blood inside or the debris inside is completely blocked. So it's not going to work. So as a chest physician or radiologist, it's very important to appreciate that, because this strain is not going to do anything, any benefit rather than harm. So that's the chest strain, and had surgical emphysema and had some pneumothorax as well. So I've got some still picture because it's difficult to follow the scrollable one. So this is the chest strain. This is surgical emphysema. So if you palpate the patient, it's crunchy. There's the pneumothorax apically, pneumothorax basally. And if you put a lung window, bone window. So without bone window, you cannot appreciate bone fracture. So it had multiple rib fractures. So that's why you need to do the windowing. So this is an acute situation I was presenting. So this is a different patient. Sorry.
Can you go back to the last image? Just one question for
Sure.
our pulmonary folks. When you have a chest tube, the port on the chest tube, could you comment on that? Now, in this case, this is not in the pleural space, this is in the parenchyma, but even if a chest tube is in the pleural space, just how to monitor the port.
Okay, sure. So it's usually monitored by doing chest X-ray. So chest X-ray is good enough. So there are proximal and distal ports, or I don't know, the side holes are called different in different countries. So you always look at, that's a very good point, always look at the side holes. This is inside suppose it's inside the pleural cavity, but sometimes it can be in the chest wall or can be outside the chest wall. So it's very important to look at that, because depending on that, patient will improve or will deteriorate. Anything else? Sorry.
Thank you.
I will have lots of chest X-ray session. I collected almost 500 chest X-rays for PHA, to be honest, to show, because that's in the middle of the talk, I'm going to say, I have been doing radiology since 2013, and I've been clinician since 2004. But chest X-ray is the most difficult modality to interpret. I always joke with my friend, I cannot interpret a chest X-ray. Imagine for the junior trainees, imagine a 3D structure is represented in a 2D format. How would you feel appreciating where the lesion is located? There is a lot of chance of error, but chest X-ray is the most common modality performed to scan any tube or chest pathology or mediastinal pathology. So it's very important to learn that. I'll have a series of chest X-ray in terms of interpretation of chest X-ray series. So please, if you have time, please join me, because I learned a lot over these years and still find it very difficult. And there are some tricks you can get away with it. You can save some lives. So this is another patient. The reason I'm showing again the density of the fluid, if you ask me, because I do radiology, I can appreciate this is slightly denser than normal fluid visually, but I am not 100% sure. Then I put ROI. This is another trauma patient for the junior trainees. She had pectus excavatum. That's why it looks so weird. So the heart is pushed towards the left side, has got a big hiatus hernia. So that's where the esophagus lies. And I'll show it. I've got another case, and I put ROI there. This patient had a trauma, basically had a fall, but couldn't tell anyone. So the mean is 43. That means it's high density. I'm 100% sure this is blood. This cannot be simple fluid. So I told the clinician this is blood. So when I see blood, what I do for the radiology training, you go to bone window straight away. Sorry, I was showing this is normal. Okay, normal is 12, and that right side one was blood. So you go to bone window, you find the fracture, because that's very important to find. What is the cause of this blood? Is it trauma? Is it, some patients cannot say what happened to them. They may be dementing. So you need to find out the cause of any blood anywhere, whether a vessel is bleeding or not. Those are the other things you need to think about. So the next patient, so ground glass nodule. So initially I thought I will talk a lot about lung nodules, but lung nodules is a different chapter itself. So I need another lecture for lung nodules. So solid lung nodules, there are different country follow different guidelines. In USA, it's Fleischner guideline, and in the UK, it's BTS guideline. Whatever guideline you follow, depending on the size of the nodule and the risk factors, you need to follow up lung nodules. just roughly saying less than 6 millimeter, you don't need to follow. This patient has got little holes in the lung, as you can see. So I can tell this is a smoker patient. So these little holes without any wall is a very mild level of emphysema. So this patient is probably a smoker. This is a small nodule. I haven't measured it, but just over 6 millimeter. It was followed, but in the middle, she lost in follow-up, like she didn't come or something like that. So initially it was very small. And then when she came back a couple of years later, that little ground glass nodule became this. I was talking about maximum intensity projection, if you remember, radiology trainees particularly. So we always look at the normal lung window and then we go to maximum intensity projection because our eyes cannot detect very small nodule in the middle of all the blood vessels. Suppose this may look like a nodule, but actually when you scroll, you can see there are branches. So this is a vessel. So the very small nodules are difficult to differentiate. So we go to maximum intensity projection to accentuate the areas of high density. The nodules stand up. It looks very nice. And you can see the nodules well. Anyway, but if you MIP or put into that reconstruction of ground glass nodule, it will just disappear. Because as I said, MIP accentuates areas of high density. It will make the ground glass nodule to go away. So don't MIP it before assessing for ground glass nodule. That's rule number 1. You first definitely have to look at lung window. I saw many trainees, they rush to look at lung window and go directly to MIP, but that's the wrong way to do it. So this patient had this mass and had a PET scan. As you can see, it's very hot, it's very metabolically active. So we do ACV max to see how active it is. The level of activity is highly avid and with a lymph node. So this patient had surgery and was cured. This is the PET imaging, but anyway, this is a different patient, a really unfortunate young patient, previous history of breast cancer. This time came in with chest pain, and you can see how awfully how awful the presentation can be. So these are all metastatic mass in the mediastinum, and also had a lesion in the lung as well, lung metastasis. And I put a picture of the brain as well. There's a brain metastasis there. There's an enhancing mass with lots of edema. So this is vasogenic edema from this mass. So the mass is small, the edema is, I'll have head CT lectures coming up soon, and I will tell you how to differentiate between a stroke or hemorrhage and all this metastatic. It's quite easy. So basically the classification for lung cancer staging is TNM8 is used worldwide. I'm not sure in Bangladesh what is used. And for the junior trainees, I put up this picture of how the stations of lymph nodes, and depending on that, the surgical consideration is made. So it depending on the tumor size and lymph node size and where the lymph node involvement is, not size, involvement of lymph node and distant metastasis. I'm not going to describe this. It's everywhere. I'll show you the sources as well. The next one was a 67-year-old man. I'm not sure whether you are looking at the heart or not. This is the most ignored part of the body when we talk about chest CT. You can see the abnormality is huge, but if you just scroll to the lungs and soft tissue, you will definitely miss it. It's a huge tumor. It's a left atrial myxoma. This patient needed surgery. Usually myxoma are small. They need only follow-up. This was protruding to the mitral valve. So this is left side of the heart. This is right side of the heart. As I said, this is right side of the body of the patient, and this is left side. And I don't have the cine images, but it was protruding to the mitral valve, and it needed to come out. This was 2 weeks ago. Okay, this case is extremely, extremely important for everybody, because I think this is one of the biggest cause of legal action from the patients in this country. Of course, the radiologist, of course. So here everything looks pretty good, but have you seen the aorta? So the aorta looks quite big. The problem is, as a clinician, probably you will not be able to measure it because I don't know the caliper for the films. On PACS, it's titrated to the, calibrated to the screen or monitor, so you can get the exact measurement. But if you see this, like compared to the pulmonary artery is huge, or compared to the aorta, pulmonary artery is huge, you need to make a comment, may ask the clinician. This patient has got a known connective tissue disease. So you need to think really carefully whether there is any pathology going on with the aorta. So suppose this patient, this was missed, this aorta is big, and comes back with this. That's a shame. A lot of patients do that, but that's a shame because you didn't pick it up. And the threshold for that. So basically for the junior trainees, this is a big flap. This is dissection of the thoracic aorta. It's extending all the way to femoral arteries, rest of the body. I'm not going into that because aortic imaging is a different thing. I will have a different lecture. I need the whole year probably. So this is the dissection flap. So that patient had Marfan syndrome with aortic dilatation. So they dilate and they rupture or have dissection eventually. So surgical threshold for normal aorta is 5 centimeters. So above 5 centimeter, people get surgery. But for Marfan, I think it's 4.5. The threshold is lower because their connective tissue weakens the wall and they get more complications. It's very difficult to surgery as well. So that's how we measure. So on axial image, you can measure if you have a DICOM viewer, you just put the caliper. And this patient had a 44 centimeter. It was incidental diagnosis. It was not, she didn't have known, she didn't have a known aortic dilatation. This is another patient. So the reason I'm showing you is 38 up to 38 millimeter is normal. So 3.8 centimeter is the threshold. Above 3.8 centimeter, you think about the body surface area and everything as well, but you need to let the clinician know. I think as a radiologist, probably that I think the aorta is dilated. Please follow up. Maybe with echo, you don't have to do CT anymore. You can do echocardiogram and follow up the aorta. Probably cardiologists know it better. So what we do, when we follow up aorta, as a radiologist, we do not do this measurement because this is basically axial plane. If the plane is tilted, the measurements is going to be either under or overestimated. So we do MPR, so multiplanar reformat. That means we make it perpendicular to the wall of the aorta, as you see, in 2 planes, so that we can get a true axial image to give you the perfect measurement. So suppose you are doubting is 4.4 or 4.7, those 3 millimeter difference makes a surgery or non-surgical decision-making process difficult. So we can give you the exact measurement by doing the double oblique. And that's the standard everywhere in the world. So that's how, for the radiology training, you have to do MPR and you have to do double oblique plane to get the true axial measurement of a vessel. So this patient who went to the dentist, the reason I put it up is he had a prosthetic aortic valve. And with patients with prosthetic valve, all the clinicians know that they get antibiotic prophylaxis before dental work, but this patient didn't get. He lives in Boston, but still the dentist didn't care, or he didn't tell the dentist that he has got prosthetic valve. So the reason I put it up, this is extremely important for radiologists particularly and cardiologists. So he has got vegetation there, which is seen on echo. This is my case from last week. At least 3 or 4 of the specialists came to me, including the surgeon who operated on him, to ask, what do I do? Like, what kind of surgery I do? So for surgical planning, he needed a CT. It's not, the CT was needed for to diagnose the valve vegetation because echo is very good. So this is the valve vegetation attached to basically this irregular thing. I've got other planar imaging I'll show you. But what is happening here, I'll show you what is happening here on the next slide as well. All this soft tissue attenuation structure, I told you, attenuation of the tissue is very important. So if I point to the fat here, and if you look at there, it's a bit dirty, okay? It should be clean fat around the aorta. There shouldn't be any space between all these places. This patient in the morning of the scan, so we scanned him in the afternoon, in the morning, he developed a complete heart block. For the junior trainees, that's an omnia sign. That means this soft tissue. So basically all this phlegmon, so we call it aortic root abscess, but the meaning of abscess is different for aortic root. So there's no wall to it. So abscess is usually enhancing a walled off structure. This is all the soft tissue attenuation around it is abscess or phlegmonous material, all infected material around the aortic root, which is basically separating the aorta from all the other structure. This is really bad. So extending along the coronary arteries as well, which is even worse. So what he had, so I compiled all the features in static images. So this is the vegetation. As I said, we use MPR to diagnose it properly. So as you see, this valve leaflet, this is non-coronary leaflet, is a bit thick, which may be degenerative. He had the valve replaced 2 years ago, so which may be normal. But how I differentiate this? This is irregular, the bottom of the leaflet of the valve. So for the trainees, these are the leaflets of the prosthetic valve, and there is a blob there. That blob is not normal. You cannot have that blob with those symptoms. So all these soft tissue is abnormal. And what this is doing, okay, all the coronaries are epicardial, so it has to run through fat. So fat is very low attenuation, okay? This is running through the pus. And what it is doing is compressing on the coronary. And also on the other planes you can see, so I will explain what anatomy I'm looking at on this sagittal plane. This is left ventricle, this is right ventricle. This is right ventricular outflow tract. This is pulmonary valve is here. So it is the pus or the infection is the front of tissues are going into the pulmonary artery and involving the pulmonary valve. So this is for the surgeons, it's very important because they may go with a bit of prosthetic what's called aortic root graft. They have to repair the pulmonary artery as well to get rid of all the pus and clear this area. Mortality depends on how much clearance you have done. The surgeons know it better. I don't know whether the surgeons are here or not. So other complications for the radiologist and the clinician, when you ask for CT scan for infective endocarditis, we can do the CT of the chest, but you may ask for abdomen and pelvis. I'm asking for more scan, but the reason is the embolic complication. We can look at it very well on CT abdomen and pelvis. Same patient had embolic infarct in the spleen. For the trainees, this is liver on the right side. On the left side, this is spleen. This is pancreas. Had a low attenuation area. The spleen is all shades of gray, so you have to just differentiate. And on the left kidney had an infarct as well. So this patient was in a state and had a surgery done with a team of surgeons and doing pretty well at this moment. So this was a case from last week. Of some extra cases, will I have time to show to the moderator? I'll very quickly show the cases.
I think we can do probably on 1 or 2 more cases.
Okay. So very quickly, this is hiatus hernia. So patient with chest pain or for any causes have a CT chest. Look at the esophagus. This is normal esophagus, quite flat and small. And there's a blob there. This is hiatus hernia. This is nothing sinister. You don't have to worry about it. The next case is basically when we do CT chest, we include upper abdomen, and you can see there are lots of low attenuation abnormality. This patient has undiagnosed adult polycystic kidney disease. So she went for a check of his gene. This is another very important thing to look at inside the mediastinum. That is this is left atrial appendage. There's a thrombus there. So if this patient need cardioversion, it cannot have cardioversion because it will shoot up and have a patient will have a stroke. Similar, I was just going to show some more clots. This patient had LV infarct and there's a clot in LV. There's more layering clot in LV for a different patient. I know I haven't had time to talk about TB, but I've got a few slides of TB I wanted to show you. So this is tree-in-bud nodularity. So TB can present in parenchymal abnormality or airway abnormality. It can go into the pleura. It can go into the chest wall. It can go everywhere. And definitely lymph nodes. So tree-in-bud abnormality there. There's more. There's some more conglomerate nodule kind of abnormality. This is miliary TB. This is consolidation-like. I'm sure you have more experience in TB than me. This is how it is affecting the bronchi, some airway air trapping in the lung because of the TB. This is bronchosil from TB. These are some mediastinal nodes. This is TB involving the pleura. So there's empyema, pericardium, and there are infection in the chest wall as well. This is TB causing Pott's disease. I think everyone is familiar with it. That's how it looks like. So last case I showed you, but I didn't discuss. I have to talk about it because we all look at CT chest. So this is coronary calcification. He's only 46. He had lots of investigation, all negative, but this is coronary calcification. And he had 3-vessel coronary calcification. I have given you some carved MPR. So look at how bad the disease is. So he had 3-vessel severe stenosis and needed bypass graft. So the reason I put it on is to show you this slide. So calcium score is done without contrast, very easily done. I don't know how available it is in Bangladesh, but comment on calcium in the coronaries whenever you read a CT chest, any type of CT chest, because this is so important. If you see the slides, all the studies were done and it showed that coronary calcium, if you add on the risk stratification, it makes a huge impact. It makes a huge difference. Patients can be on statin and you can prevent a heart attack of the patient if you put them on statin, the asymptomatic one. So I was talking about we can only see anatomy, we cannot see functional information, but some of you are aware in Bangladesh that we do coronary CT angiogram and we can do the full function on CT. So what we do, we capture the whole cycle, and this is left side of the heart and this is the right side, and you can image systole and diastole. You can have all the functional information as well from a CT scan. And something called FFRCT is in place now, is widely used. This is kind of equivalent to FFR you do invisibly. I'm not going to, I'm just showing the pretty picture, but I'm not going into this. So take home messages. Again, emphasizing clinical context is very important. And that's how we protocol the study and how we tell you what's wrong with the patient. Special consideration of renal function, pregnancy, pediatric patient, very carefully needs to be looked at. Use all windows and post-processing technique. If you don't have PACS, then ask the radiologist to give you some more windows if you are querying a particular structure. Comparison with previous is extremely important. It's true for every modality you do. If you do a chest X-ray, compare with the previous, so encourage the patients to bring the previous images, previous films probably. I would recommend clinician to keep normal CT, maybe the films of normal CT and one of your image viewers, so that you can always compare anything abnormal. And you can explain to the patient probably that this is a normal and your one is abnormal because of this reason. This is pattern recognition. If you are very used to see normal studies, it will be very easy to differentiate the abnormal one and go through the anatomy one by one. If you're following a vessel, just follow the vessel. If you're following the right side of the lung, just follow the right side of the lung according to how it is given to you on the film. And structure report is very important. This is for radiologists because I know our patients in Bangladesh, they come with a radiology report from one clinician and then eventually go to another clinician and another scan is happening in another department. So the results are very difficult to compare with. And the clinician, particularly the oncologists, are in big trouble because they don't know which lymph node they're talking about, which part of the lung they're talking about. So if there's a system we can develop where we can give a structured report and we talk about the same thing, it is going to be really, really helpful for the clinician. And communication is clear. Communication is the key, actually. We have to do this because otherwise we'll not get the right answer for the right question. And last not on the list, don't ignore the heart, aorta, coronary calcification, at least on the chest CT. Some references or further reading. I'm going to give you some important resources for trainees for any radiology. You can go to Radiology Assistant. Radiology Masterclass is very good for basic interpretation of anything. And Radiopedia is the Wikipedia for radiology. I go every day. So if you have any question about anything, you can just put it on. Thank you so much.
Thank you very much. That was an excellent lecture. I think we all learned a lot. I would request all the panelists and the co-hosts to turn their video screen on, and we'll hear from the panelists first. Could you mute if somebody has the microphone on? Okay. I would like to thank you again, Dr. Sultana, for your excellent lecture. It was very helpful. as for clinicians and definitely for radiology residents and radiology trainees. I'm going to ask I'm playing two roles here today because Aisha had to leave. I will start with Dr. Asif Mustabali to hear his comments from the panelists first, and Dr. Ali Hussain at the end. He is a chairperson also. Dr. Asif Mustabali.
Thank you very much. Presentation from Dr. Sajid. You covered a lot of ground, and I'm very thankful to PHA for inviting you to make this talk because it covered pulmonologists, clinicians, as well as it was very helpful for your junior trainees in radiology. So it helps a lot. It is the cases were very illuminating to us, and particularly along the clinical history. And of course, TB in this part of the world and anywhere in the world is can be difficult often. You showed some classical cases. From my perspective, I think that we can also utilize CT in certain cases of latent TB, because latent TB is now being given special interest in Bangladesh also. So it's our job to rule out active TB in patients who have quantiferon or monocytes positive, I'm sorry. So it's our job to make sure that they don't have active TB before we put them on TB preventive therapy. And I believe that with our knowledge of CT, we can even identify smaller active foci in the lungs. Thank you once again for your brilliant presentation, and we look forward to having you on our series in the future as well. Thank you very much.
Thank you, Dr. Mahmood. Dr. Rumi Khan, your comments, any take-home messages for our participants?
Hello, everyone. Good evening, whatever you are. Sadly, it was a very difficult task to put everything in 1 hour lecture, because also congratulations on training in chest radiology. It is a very rare specialty. We are always in search of radiologists who have interest in chest. So you will be very much needed in our common day-to-day practice. And we're looking forward to your more service in our practice, education, teaching. And I personally, because of with the lack of radiology specializing in chest, we just kind of do our own makeshift training for our trainees, fellows. And for you, within 1 hour, it was extremely difficult to accommodate everything. I just wanted to get the opportunity to show 2-3 slides to all the pulmonary fellows, pulmonary trainees are here to add on. I know if you have the time. So if I can share some of my slides, that will be helpful.
Okay, and I'm going to do that. How long? All right.
Yeah.
Go ahead. Can you share your screen now?
Yeah, I'm sharing now. Do you see it?
Yeah, maybe 2-3 slides and then go.
So one thing I wanted to make a point for us, pulmonologists, is that the importance of HRCTs. This is a 1 millimeter cut versus 10 millimeter cut. You can see how clearly we can make a case of the honeycomb that we could not see in the low-res CT scan. So this is very important to pinpoint that we need to understand this high-res CT scan for ILD specifically. Then also when you deal with ILD, especially UIPs, to learn the lines, interlobular and interlobular lines, they're extremely important to learn the lines. These are the lines we see here. This is the interlobular line, in between line, that is fluid or cancer, or you can look at the intralobular line. The lines go through lung lobe. They don't follow one lobe. They are going through and through. This is very important for chest physicians to learn the line. This is the intralobular lines versus you see here in this side. In this side, you are seeing line that is not following any lobe, is going to a interlobular line. So these lines are your first determinant of ILD reticulations. And then you see all the honeycombings, and we are learning this traction bronchiectasis, as Sadia said. Also, we are lately we are learning to differentiate between IPF versus UIP secondary to other connective tissue diseases. Like a lot of work being done by Jonathan Chang at Chicago, and this is the thing I'm showing to you. That the three signs that separates UIP from IPF versus UIP from some other connective tissue disease like RA or something else, like straight edge sign, exuberant honeycombing sign, anterior upper lobe signs. So you see that in this thing, this is very, very plump, very big sized honeycombs. These are exuberant honeycombs. These are the very classic of UIP secondary to a connective tissue. It is not IPF. Very exuberant. Whereas you see that when you see a straight upper edge of where the honeycombing ends, straight edge sign, another sign of UIP secondary to connective tissue disease. So these are the things we are slowly learning in recent years from Jonathan Chang, others' work, that we even don't need serological panel. From CT scan itself, with 87 to 90% sensitivity specificity, we can tell this is the UIP secondary to some connective disease. Also, this anterior upper lobe sign. Another thing, I always saw it in a scan. I never could understand the importance of it. Everything at the base, suddenly the anterior upper lobe, the honeycombing. When you see honeycombing in the anterior upper lobe, also another sign of UIP secondary to connective tissue disease. So these are the three things we are learning actually more and more. And you see here UIP secondary to IPF. Here it is not straight edge, it is kind of curved. It is like going up like pleural fluid. If it was from secondary to connective tissue disease, it would have been straight edge, but it's not the case here. So that is a thing we are learning as we go lately, but I will end up here. Thank you for giving me the opportunity. But I hope Sadia will talk more about this detailed stuff in the future series. This 1 hour is not enough for anything, Thank you very much.
Yes, this the whole CT scan, just the CT chest probably is at least, if you go deep down into ILD nodules, each one is more than an hour lecture.
Yeah.
Thank you, Dr. Khan. I'm going to ask Dr. Farzana Alam from Bangladesh. Are you still there for your comments? Yes.
Yeah, thank you.
And I think a lot of this will be what we heard so far is pretty much from the US and the Western standpoint. What is applicable in Bangladesh? If we could address that, that would be great.
Thank you very much. আমি একটু বাংলাতেই বলি, মনে হয় সবাই বাঙালি।
হ্যাঁ, সবাই বাংলা বলতে হবে।
সাদিয়া, আমি আসলে সাদিয়ার ফ্যান। ঠিক আছে, ও জানে না যে আমি ওর ফ্যান। সো সাদিয়া আমার 2 বছরের জুনিয়র, আমি কি 53। যাই হোক, তো আমি খুব খুশি হয়েছিলাম 2 বছর আগে জানতে পেরেছি যে ও রেডিওলজিতে আসছে। আজকে অনেক আমার ট্রেইনিদেরকেও ইনভাইট করার কথা ছিল। আই এম সরি আই কুডন্ট ডু দ্যাট। নেক্সট টাইম আই উইল অর্গানাইজ দোজ থিংস ইনশাআল্লাহ। এন্ড আজকে সাদিয়া যেসব কথা বলেছে, ভেরি গুড লেকচার, এবং এইটুকু সময়ের মধ্যে she tried to show so many things, and it has become so interesting also, the lecture. And I want to emphasize few things of what she has also emphasized. For us, for radiologists, we need the history. Actually, first of all, we need the history. And I teach my students that the chief complaint, the presenting complaint of the patient is Porosh Pathor for you. So I ask them, what is your Porosh Pathor? Whenever my students, they show me the drafts, I first ask, what is your Porosh Pathor? Because we go through the chief complaints, and if we get more clinical information, it gives us more confidence to give the diagnosis and those things. And what I feel, in Bangladesh, we don't have that much good infrastructure, but we need to serve our 16 crore of people. So what we need to have good communication between the radiologist and the physician. And this platform, Sadia, when she was talking about me and she was telling Apu, আমরা যদি ক্লিনিশিয়ানের সাথে ভালো সম্পর্ক থাকে তাহলে তো পেশেন্ট ম্যানেজমেন্ট ভালো হবে। অলওয়েজ she was focusing on patient management, and of course this is our ultimate goal and this is our only goal to manage the patient. এবং এই প্ল্যাটফর্মটাকে এই জন্য আমি অনেক ধন্যবাদ দেই এবং আশা করি আমরা এই যে হিস্ট্রিটা আমাদের যদি কমিউনিকেশনটা খুব ভালো থাকে, যেটা সাদিয়া এমফাসাইজ করছে, আমরা হচ্ছে খুব ভালো পেশেন্ট ম্যানেজ করতে পারবো। প্লাস পেশেন্ট আরেকটা জিনিস হচ্ছে ক্লিনিশিয়ানদের কাছ থেকে যেটা সাদিয়া বলেছে যে প্রিভিয়াস ইমেজ, আমরা যে আমাদের এখানে যখন পেশেন্টরা আসে আমরা প্রিভিয়াস ইমেজ পাই না, উই কান্ট কম্পেয়ার। আমি হয়তো আইএলডি বললাম, এটা ইনক্রিজ করলো কি করলো না আমি তো বলতে পারছি না উইদাউট প্রিভিয়াস ইমেজ। একটা ক্যান্সারের পেশেন্ট আমি প্রিভিয়াস ইমেজ না থাকলে পারছি না। এবং আমাদের বাংলাদেশে আমরা আরো যে একটা সমস্যা পাই, মাঝে মাঝে লোকে বলে, পেশেন্ট বলে, ইভেন মাঝে মাঝে সবাই তো একরকম হয় না, ক্লিনিশিয়ানও বলে যে আপনার এত কিছু জানার কি দরকার, আপনি ইমেজ দেখে বলে দেন কি আছে। তো তখন আমি বলি আই এম নট এ টেকনোলজিস্ট, আই এম এ ডক্টর। এবং আমি ইমেজের ডায়াগনোসিস দেই না, আমি ডক্টর, আমি পেশেন্টের ডায়াগনোসিস দেই। সো এবং সাদিয়ার আরো যেটা ভালো লেগেছে যে স্ট্রাকচার্ড রিপোর্ট, উই আর ইন ল্যাক অফ এ গুড রিপোর্ট ফরম্যাট, যেটা আমরা আসলে গ্র্যাজুয়ালি উই হ্যাভ টু ডেভেলপ যাতে। এবং আমি সবসময় বলি যে উই হ্যাভ উইথ দ্য রেডিওলজিস্ট উই আর টু মেক we have to make the clinician's job easier and more perfect. We are at your service এবং আমাদের সার্ভিসের কনজিউমার হচ্ছেন আপনারা ক্লিনিশিয়ানরা, এবং ওই জন্য আপনাদের ইনফরমেশন আমাদের খুব দরকার। আমি আজকেও সকালবেলা ঢাকা মেডিকেলে গিয়েছিলাম, নিউরো সার্জারি ডিপার্টমেন্টে, একজনকে বলে এসেছি, তুমি রেজিস্ট্রারকে বলেছি যে তুমি সব আমাদের ফল্টগুলোকে রাখবা এবং আমি সহ আমার স্টুডেন্টরা আমরা তোমার কাছ থেকে সেশন নিব আমাদের যেসব ভুল রিপোর্ট সেগুলো দেখার জন্য। তো সেই ক্ষেত্রে হচ্ছে যে স্ট্রাকচার রিপোর্টটা আমাদেরকে আরো হেল্প করবে, আপনাদের কাছে আপনাদের সার্ভিস দিতে পারবো এবং উই নিড ইয়োর ফিডব্যাক। সো সাদিয়ার অনেকগুলো এই সবগুলো জিনিসের সাথে এই যেগুলো হচ্ছে পেশেন্ট ম্যানেজমেন্টের এই স্টেপ গুলো এসছে এবং তার অ্যানাটমি থেকে শুরু করে সবকিছুই she wanted to make easier for us. Thank you সাদিয়া, অনেকদিন পর দেখলাম রে।
Thank you.
আচ্ছা, thank you all.
Thank you, Dr. Alam. I'll now ask Dr. Osmani, if you could give your comments. Yes, thank you.
Hello, this is Osmani from Bangladesh. First, I'd like to thank Sadia for majestic presentation, beautiful presentation in a big window. And the thing is that, like, the other thing I like to say about the organizers, they're doing very good to linking the advanced countries with a country like us. And you people, you are doing very good. We are proud of you. And in any program, when I see you in the windows, I become very happy that I can even feel proud of it. You are doing some advanced work in advanced countries. People like us in Bangladesh, we are fond of like new informations and everything. In my day-to-day practice, CT is an important tool for us. We always say it like, in chess, every specialist is a cousin. You cannot do without your cousins. So cardiologists, pulmonologists, even a neurologist, even internist, all together in the chest, it is very important for us. For the cardiac point of view, I had talked with Sadi earlier. I always like to say that what I want to know from CT for my cardiac practice, clinical practice, Sadia has told all the aspect of this thing once, and I like to thank Sadia once again, and I like to request her to have a small window for cardiology in CT, like we can learn about coronary calcium scoring, we can learn about our other utilities of CT in cardiac departments. And Sadia, it was very nice of you to invite me in this situation. I'll belong and I'll wait for next episode also. Thank you very much, and thank you all the attendees and mentors. It was a very long day for me. I start up at 7 and it's mid of the night. And take care, everybody. We are proud of you. Thank you.
Thank you, Dr. Osmani. It was, yes, and we're running a little late, but it was such a wonderful talk and good discussion. We just couldn't go. I will now ask Dr. Hanif. I think I saw Dr. Hanif on, yes, for his comments.
Assalamu alaikum. শোনা যাচ্ছে?
হ্যাঁ, শোনা যাচ্ছে।
জি, তো অনেক রাত হয়ে গিয়েছে আসলে, আমাদের এখানে প্রায় 12টা বাজছে। সাদিয়ার ব্যাপারে সবাই সব কথা বলে দিয়েছে। ফারজানা বলেছে, সাদিয়াকে খালি আমি একটা কথা বলবো, আমি তোমার লেকচার গুলা স্লাইড গুলা দেখছিলাম আর চিন্তা করছিলাম আমি পেডিয়াট্রিক সার্জন না হয়ে রেডিওলজিস্ট কেন হলাম না। তো এটা আসলে আমার এত সুন্দর করে এগুলা এক্সপ্লেইন করছিল, ডায়াগনোসিস গুলা বলছিল, খুবই চমৎকার। আমি নিশ্চিত যে আমাদের যদি ট্রেনিরা থেকে থাকে তারা খুবই উপকৃত হবে এগুলা দেখে, কারণ আমাদের সময় এই জিনিসগুলো ছিল না। আসলে আমাদের আন্ডার গ্রাজুয়েটে এক্সরে উপরে আমরা এখনো যেটা ধরি, একটা প্লেন এক্সরে, আমি পেডিয়াট্রিক সার্জন, একটা পারফোরেশনে কি কি জিনিস থাকবে এইটার উপরই আমরা বোধহয় মেডিকেল স্কুলে এটা আমরা আমাদের একটা কমন কোশ্চেন থাকে, ফ্রি গ্যাস থাকবে আর কি থাকবে, এটা এখনো ধরা হচ্ছে। সো এই সিটি স্ক্যানের এই সুন্দর জিনিসগুলো ফারজানা বলতে পারবে। আমার মনে হয় না আমরা আন্ডার গ্রাডে কোনো পরীক্ষাতে এগুলো ডায়াগনোসিস তারা করতে পারে, বা আমাদের কারিকুলামেও সেইভাবে আসলে নাই। তো খুবই চমৎকার। আমি আশা করব সাদিয়া এই সে বলছিল সে 500 এক্সরে কালেক্ট করেছে। আমার একসময় সব কিছু এক্সরে কালেক্ট করা, তাও সব মিলাই বোধহয় 50টা হবে না। তো সে অল্প কয়েকদিনের মধ্যেই বলল যে 500টা তার কালেকশনে আছে, এবং সে এক লেকচারের এক পর্যায়ে বলেছিল যে তার 1 বছর লাগবে এগুলো দেখাতে গেলে। আর সাদিয়াকে আমি আবার ধন্যবাদ দিই। আমি সপ্তাহ 2 আগে বস্টনে গিয়েছিলাম, সে 3 বাচ্চাকে বাসায় রেখে কাজ করে সকালে, একটু আগে আমাদের আর এক কলিগ বললো সকাল 7টায় উঠেছে, সে সেরকম সকালে বের হয়ে সন্ধ্যায় এসে আমাকে দেখা করে গিয়েছে। এবং বস্টনে না, নিউ ইয়র্কেও সে আরেকটা আমাদের তুষারের বাসায় একটা গেট টুগেদার ছিল, সেখানেও সে কষ্ট করে এসেছে। সেজন্য সাদিয়াকে অনেক ধন্যবাদ, কৃতজ্ঞতা জানাই। আর আমি আশা করব এই তার এই যে ক্লাসগুলা, এটা আজকে সেটা বলেছিল যে একদম ট্রেনি জুনিয়রদের জন্য, কিন্তু আমার কাছে বেশ অ্যাডভান্সে মনে হয়েছে। আরো বেসিক এক্সের উপর যদি একটু ক্লাস নাও তুমি ট্রেনি এবং এমবিবিএস লেভেলটা আমরা হয়তো অ্যারেঞ্জ করতে পারি 5th ইয়ারকে টার্গেট করে, সেটা হয়তো করা যেতে পারে। আমার মনে হয় তোমার খেয়াল আছে তোমার সময় যেভাবে এক্সরে পড়ানো হতো এখনো সেই অবস্থায় আছে, খুব একটা হেরফের হয় নাই। কিন্তু ফারজানা কি সহমতে ব্যাপারে?
জি স্যার। স্যার আমি আসলে আনমিউট হয়ে আছি আপনাকে একটা কথা বলার জন্য, যেটা স্যার একটা মানে এইটা আমি জানি না মানে উন্নত বিশ্বে কি রকম, কিন্তু আমাদের দেশে আই ফিল যে রেডিওলজিস্ট ক্যান সি, and he who can see he can guide, he can lead. তো আমরা রেডিওলজিস্টরা আসলে গাইড করতে পারি, কিন্তু আমাদের বাংলাদেশে 2-3টা সমস্যা খুব বড়। তার মধ্যে যে একটা সমস্যার সমাধান আমার মনে হয় আপনার হাতে স্যার, সেটা হচ্ছে রেডিওলজিতে ইন্টারেস্টেড হচ্ছে না। রেডিওলজিতে যারা আসছে তারা সাধারণত স্যার এটাকে খুব রিল্যাক্সিং একটা সাবজেক্ট ভেবে আসছে, কিন্তু রেডিওলজি ইটস এ হিউজ স্যার, এবং রেডিওলজিস্ট ক্যান গাইড, রেডিওলজিস্ট ক্যান মিসগাইড। কাজে পেশেন্ট ম্যানেজমেন্ট ততদিন আমরা খুব ভালো পর্যায়ে নিয়ে যেতে পারবো না যতদিন রেডিওলজিস্ট ভালো কাজ না করবে। এটা স্যার ফ্যাক্ট যে এখনো আমাদের বহু ভুল রিপোর্ট আপনারা পান, তাতে রেডিওলজিস্টের এটা শুধু যে আমি বলবো রেডিওলজিস্ট দায়ী তা না স্যার, আমাদের ইনফ্রাস্ট্রাকচার, আমাদের আপনারা হয়তো জানেন যে আমরা খুবই পোরলি পেইড, এটা অনেক বড় একটা ব্যাপার। কিন্তু আপনার হাতে যে ব্যাপারটা স্যার, সেটা হচ্ছে ছাত্রদেরকে রেডিওলজি পড়তে উদ্বুদ্ধ করা। এইটা স্যার খুব দরকার আমাদের পেশেন্ট ম্যানেজমেন্টকে ইমপ্রুভ করানোর জন্য। কিছু ডেডিকেটেড মানুষ দরকার আমার এখানে স্যার। আপনি ঢাকা মেডিকেলে আছেন, আপনি অনেক ছাত্রদের মধ্যে, আমরা যাব, তাদের সাথে কথা বলবো, তাদেরকে এনকারেজ করার চেষ্টা করব স্যার। এবং আপনি একটা জিনিস চিন্তা করেন স্যার, একটা হসপিটালের সমস্ত রোগী, সব ডিপার্টমেন্ট মিলে যত রোগী, এক রেডিওলজি ডিপার্টমেন্টে তার 2-3 গুণ রোগী। কারণ হচ্ছে সবারই ইনভেস্টিগেশন লাগে এবং মোর দ্যান ওয়ান ইনভেস্টিগেশন লাগে। তাহলে আমি এক একটা ইনভেস্টিগেশনকে একটা রোগী ধরলে আরো বেশি রোগী, তাহলে কত রেডিওলজিস্ট দরকার। এবং রেডিওলজিস্ট ক্যান মিসগাইড, কাজেই রেডিওলজিস্টকে অনেক বেশি পারফেক্ট হতে হবে। এই জন্য আমাদের স্যার ওই রকম টিম দরকার। আপনি মানুষ তৈরির কারিগরের ভিতরে আছেন স্যার, আপনার হাতে যারা থাকে তারা এখনো কাদামাটি, তাদেরকে যদি আপনি এনকারেজ করেন, আমরাও যাব, তাদের সাথে কথা বলবো রেডিওলজিতে ক্যারিয়ার করার ব্যাপারে। স্যার আমি নিজেও রেডিওলজিতে এসেছিলাম, আমি ভেবেছিলাম এইটাতে থেকে হয়তো আমি আমার ফ্যামিলি, বাচ্চা সব মেনটেন করতে পারবো সহজ করে, কিন্তু এসে যখন দেখি রেডিওলজি হিউজ, আই কান্ট ডিপ্রাইভ মাই সাবজেক্ট। স্টিল আমি স্যার বাইরে, আমি কিন্তু বাসায় না, আমি সকাল 6টার সময় বের হয়েছি। তো এইটা এখন স্যার এইরকম না হলেও এর হাফও যদি সবাই করে, তাহলেও স্যার আমাদের আরো ম্যান পাওয়ার দরকার এবং কিছু ডেডিকেটেড মানুষ দরকার। আপনার সাহায্য প্রার্থনা করছি স্যার।
থ্যাংক ইউ ভেরি মাচ ফারজানা। আলী হোসেন ভাই থেকে আমি একটু সময় চেয়ে নিচ্ছি। আলী হোসেন ভাই পর একটু শুনবেন। আর তুমি যে কথাগুলো বললে, আসলে সাদিয়ার একটা লাস্ট কথা, একটা কমিউনিকেশনের কথা ছিল, কোলাবোরেশনের কথা ছিল। আমার 2টা ছাত্র 2টা থিসিস করেছে রেডিওলজি ইনভলভ করে। একটা ছিল তোমার ইন্টারসাসেপশন আর্লি আসলে আমরা এটাকে হাইড্রোস্ট্যাটিক রিডাকশন করেছে সে, এবং সেখানে রেডিওলজিস্ট তাকে গাইড করেছে এটা রিডিউস হলো কিনা। আরো একটা ছাত্র করেছে যে আমাদের অ্যাপেন্ডিকুলার অ্যাবসেস আমরা সার্জারি না করে সেটাকে আমরা ড্রেন করেছি। একবার হয়েছে, অনেক সময় হয়তো 2বার লেগেছে। সো এই কোলাবোরেশনটা আমাদের আছে। এবং তুমি যেটা বললে রেডিওলজিতে যে পরিমাণ ভিড়, ঢাকা মেডিকেলের রেডিওলজি কর্নারে যদি আমি গিয়েছিলাম ওই দিন, ওখানে হাঁটা যাচ্ছিল না। আসলে ঢাকা মেডিকেলে তো সারা দেশ থেকে অনেক বেশি রোগী আসে। তারপরে তোমার যেই পেইডের কথাটা বললা, আমরা একটা উদ্যোগ নিয়েছি, বেসিক সাবজেক্টে আসলে আমাদের টিচার নাই, সেজন্য আমরা তাদের অ্যালাউন্সের সমপরিমাণ একটা ভাতা দেওয়ার জন্য আমাদের একটা দাবি ছিল, সেটা অনেক কম দিয়েছে, সেটা আবার আমরা উদ্যোগ নিয়েছি। এখন এখানে রেডিওলজিটা অবশ্য নাই, বেসিক সাবজেক্ট আছে, সাথে অ্যানেস্থেসিয়া আছে। সো এটা রেডিওলজি হয়তো ইনক্লুড করা যায়। আর 8টা মেডিকেল কলেজের রেডিওলজি ডিপার্টমেন্টকে ইমপ্রুভ করার জন্য জাইকার একটা প্রজেক্ট নিয়েছে, এটা বোধহয় তুমি জানো, আন্ডার ওয়ান রুফ সেই কাজটা হচ্ছে। সুতরাং রেডিওলজিকে আসলে যথেষ্ট গুরুত্ব দেওয়া হচ্ছে। তবে যেটা বললে, আরো যাতে ছেলে মেয়েরা এতে ক্যারিয়ার করতে আসে। এবং এখন আসলে রেডিওলজিতে অনেক কাজ, ইন্টারভেনশন রেডিওলজি তো আমি বলবো খুবই মানে চমৎকার সাবজেক্ট। আমার নিজের ভাতিজি ইয়েতে আছে, ম্যাথস জেনারেলে, সার্ভার থেকে পাশ করে সে ইন্টারভেনশনাল রেডিওলজিতে কাজ করছে। সো এটাকে তোমরা আসতে পারো, এটা আসলে কিভাবে এটাকে আরো ভাইব্রেন্ট করা যায় সেটা আমরা চেষ্টা করব। কিছুদিন আগে মোয়াজ্জেম, আমাদের পরের ব্যাচের K40, ও ইউনিসেফ আছে নিউ ইয়র্কে, তো ও একটা প্রেজেন্টেশন করেছিল পাবলিক হেলথের, যে একসময় কেউ কোথাও না পড়তে পারলে হয়তো পাবলিক হেলথে যেত। তো ওর টপিকটা ছিল যে নট বাই চান্স বাট বাই চয়েস। সুতরাং আমি মনে করি রেডিওলজি এখন যে পর্যায়ে গিয়েছে, এটা অনেকেই চয়েস দিয়েই পড়বে। তো এটাকে তোমাদেরও একটু মোটিভেট করার বিষয় আছে। আর আমি ধন্যবাদ জানাচ্ছি প্ল্যানেটারি হেলথ একাডেমিয়াকে যে আমাকে আজকে এখানে থাকতে বলার জন্য। আর সাদিয়াকে আবারও অনেক ধন্যবাদ জানাচ্ছি। আর ডিটেল যে জিনিসগুলো, এখানে আলী হোসেন ভাই আছে, আমি আদনানকেও দেখেছিলাম, আরো যারা রেসপিরেটরি মেডিসিনের আছে তারা বলবেন। তবে আমি একজন লেম্যান, পেডিয়াট্রিক সার্জন হিসেবে আমার কাছে মনে হচ্ছে তোমার প্রেজেন্টেশনটা খুবই সুন্দর হয়েছে এবং অনেক ডিটেইলে হয়েছে। তো এটা আরো করবে, এটা আমার আশা থাকবে। সবাইকে অনেক ধন্যবাদ। আসসালামু আলাইকুম।
Thank you, Dr. Hanif. We still have a lot of panelists to hear from. I will ask Dr. Habib Rahman Pulway, any comments from you? You're still muted. আপনার এখনো মিউটেড।
এখন বোধহয়
এখন শোনা যাচ্ছে। হ্যাঁ, থ্যাংক ইউ।
না? আচ্ছা,
রাইট।
সবাইকে আসসালামু আলাইকুম। যেহেতু সময় খুব সংক্ষিপ্ত, জাস্ট কুইকলি ওই যে লেটেন্ট টিভির ব্যাপারে যে ভাই কমেন্ট করলেন, সিটি স্ক্যান, রোল অফ সিটি স্ক্যান ইন লেটেন্ট টিবি, তো এই বিষয়টা এখনো স্ট্যান্ডার্ড হয়নি। আমি যেটা মনে করি তা হলো যে যদি এক্সরে যদি গুড কোয়ালিটির হয় এবং এক্সরেতে যদি ডাইরেক্ট এবং ইনডাইরেক্ট সাইন যেগুলো সেটা নিয়ে এখন আলোচনা করার হয়তো আগামীতে রেডিওলজিস্ট এটাকে আরো ক্লিয়ারলি এক্সপ্লেন করবেন। সমস্ত কিছু যদি দেখা যায় তাহলে মোটামুটি ভাবে সিটি স্ক্যানের রিকোয়ারমেন্ট যেটা সেটা অনেকখানি নিউট্রালাইজ করা সম্ভব। যদিও আর্টিকেল আছে আমরা জানি পড়েছি যে আপ টু 30% ক্ষেত্রে যদি সিটি স্ক্যান করা হয়, যেখানে আমরা টিবির ক্লাসিফিকেশন করি ক্লাস 2 থেকে ক্লাস 5 পর্যন্ত, দেখা যায় যে ক্লাসিফিকেশন অনেক সময় আপগ্রেডেড হয়, ক্লাস 2 থেকে হয়তো ক্লাস 5 হলো, সামথিং লাইক দ্যাট। তো কাজেই দিস পার্টিকুলার এরিয়া ইজ নট রিয়েলি স্ট্যান্ডার্ডাইজড ইয়েট, বাট অফকোর্স ইটস এ গ্রে এরিয়া যেখানে সিটি স্ক্যান মে হ্যাভ এ রোল অ্যাট লিস্ট ইন সিলেক্টিভ কেসেস, কিন্তু জেনারেল স্ট্যান্ডার্ড করাটা ইজ এ বিগ ডিসিশন টু মেক। আর আমি জাস্ট রুমিকে একটু ধন্যবাদ জানাতে চাই, যদিও অ্যাডভান্স লেভেল, কিন্তু তুমি যে ডিফারেন্সিয়েশন গুলো বলেছো between UIP due to IPA and UIP due to non-IPA related etiology, I think that was wonderful. সবাইকে ধন্যবাদ।
Thank you. Thank you, everyone. Dr. Professor Ali Hassan, if you could give your comments.
Dr. Shahin.
Shona, that's it.
Thank you, PHF, for inviting me. This is something in this session. I am really grateful to Sadia for her excellent presentation and elaborate presentation. She has actually mentioned everything in her lecture. Actually, as a pulmonologist, we encounter CT almost every day. And I think that it is many of the disease can be diagnosed from the CT. That does not mean any biopsy or any intervention. Especially in DPLD, if we divide the zones, upper and mid and lower zone, we can just reach in a conclusions that this could be this type. Then according to that type, actually, we can proceed for the investigations for confirmations. It does not need a lot of investigations in that particular disease. And she has rightly shown the different emphysematous changes, bronchiectasis, and many things. And even in bronchiectasis, by seeing the distribution of the bronchiectatic cavities and the other things, we can say whether this is fungal origin or as invasive aspergillosis. We can easily find it from the CT. So it is one of the most important investigations. And many of the chest diseases, in early, it cannot be diagnosed from the X-ray. And if we do the CT, we can diagnose many of the chest diseases very early stages. And even in simple pneumonia, if we do chest X-ray on first day, we cannot see anything. But if we do the CT, we can find the consolidations. So I think that CT has got a very important contributions for diagnosis of the chest diseases and for its management. And she has rightly mentioned all these things very elaborately, and she has enriched our knowledge. Thank you, Sadia, for your excellent and brilliant presentations. Thank you all the panelists for their brilliant contributions. I think that we have enriched our knowledge from her lecture. Thank you all. Thank you very much.
Thank you, everyone. And Sadia, it was wonderful. I did not know about the ECG-gated CT, although, like I said, when I teach my residents fellows, I always say, as a pulmonologist, we do three things: get a chest X-ray, CT scan, and then do a bronchoscopy. But there's a lot in between, actually, that, like Dr. Professor Ali Hassan said, you can actually make diagnosis from just looking at the CT scan. It was a wonderful lecture. I think we're looking forward to hear from you more, especially like in the...
Add something, sorry to interrupt. That interstitial lung disease is a completely different talk. So that's what I'm saying. So I didn't go into detail of how to differentiate. So that's what I'm going to do in a separate session, because it's more than 2 hours talk actually. And about chest X-ray, I just want to make a comment about a WBI's comment, basically, that as I said, I'm just saying it again and again. I have been doing radiology since 2013, and chest X-ray is the most difficult thing for me to interpret. So this is the 2D representation of a 3D structure. So you cannot unlearn or learn more, basically. So this is not for only medical students, I would say. The mentors who are here, for all your junior doctors, even yourself, the chest x-rays, interpretation, and to keep on top of it is very important because that's the first investigation we do. So the series I'm going to do will have all about tubes and lines, will all about, pneumothorax, pneumoperitoneum, pneumomediastinum, so all the different series will happen. So please join us.
Yeah, thank you.
Thank you.
We still have the specialist experts from Bangladesh. One suggestion I have, we struggle here also to get the old images. That's a pain because in this country, if you get CT done at a different institution, we don't have ways to view it unless they bring the CD. And I'm sure that's more pronounced in Bangladesh. কিন্তু এটা কি সম্ভব যে ধরেন maybe we can have a cloud system so everybody loads their CT so we can access. It is a big project, but I think যারা বাংলাদেশে আছেন তাদের জন্য that may be an opportunity. I had thought about copying these CT images on a flash drive. It 2006-07 যখন আমি fellowship করছিলাম, we tried. People lose it, but if we have a cloud system, that might work better. That'll be something I think বাংলাদেশে যারা আছেন তারা যদি চিন্তা ভাবনা করেন কোনো grant foundationের মাধ্যমে, that'll be an option. But any comments from anybody? I'm opening it up to all the participants and panelists. Any other comments that they would like to bring up? Well, going once, twice, no more comments. There was actually one comment, Sadia, to discuss the indications of MRI, but that'll be a different talk. When you do the MRI talk, probably bring it up. I'm looking at the chat room if there's any other discussions. But yeah, well, thank you everyone for joining. It was a wonderful lecture. We all had good time. I know in the US it's just the morning, but in Bangladesh it's late evening. You all have a good night and we'll meet again in the future. Thank you.
Thank you.
And thank you for PHA for organizing this.
Assalamu alaikum. সবাইকে শুভ রাত্রি. Good morning.
Good morning.
Take care. Bye.